I'm Chad Naughton, U.S. Professional Relations Manager. Welcome to today's broadcast from Dr. Dan Patikny entitled Clinical Considerations with New Generation Translucent Full Contour Zirconia. At the conclusion of the pre-recorded portion with Dr. Patikny, we will have Dr. Patikny live via phone to answer any questions you may have during the course of the broadcast. So if at any time during the broadcast you have a question, please submit those questions and we will answer as many questions as we can. Today's presentation is brought to you by 3M Healthcare Academy, where you can find a wealth of educational material in a variety of formats. A little bit about our presenter, Dr. Patikny. He's been practicing dentistry in Texas since 1983, and over the course of his distinguished career, he's held positions as an adjunct clinical associate professor at University of Michigan. He's a fellow at the Academy of CAD/CAM Dentistry, and has received numerous awards and recognitions for his expertise in dental materials, CAD/CAM, and restorative dentistry. His practice philosophy can best be summed up as the trained professional has merely earned the right to become a student for life. As a reminder, not all products are available in all countries. Product name and package may vary from country to country. For more information, please contact your local 3M rep or visit 3m.com/dental. This webinar was prepared and authored by Dr. Dan Patikny. The opinions expressed in this webinar are the author's own and do not necessarily reflect the view of 3M Oral Care Solutions and 3M Company. Ladies and gentlemen, Dr. Dan Patikny.
Hello, I am Dr. Dan Patikny, and I'm happy to be with you today. In today's webinar, we're going to discuss a new generation of materials that I think will have high impact on your clinical practice. And we're also going to look retrospectively at the material class itself, particularly as it relates to the ceramics, with a little bit better understanding perhaps of how mechanical properties influence our choices of materials and how the applications may benefit us actually. We're also going to look at clinical considerations and techniques for the use of these materials as well. So in short order, we're going to have a better understanding of what these ceramics mean to us and how they will apply to us in the future. If you look today and you look a few years back, it's clear, particularly in the span of time that I've been practicing, that much has changed on the material front. Today, we have much wider range of choices to aesthetically and cosmetically serve our patients. We also have materials that are particularly robust. To make a point, the ceramics that we're currently using today were not the ceramics that were used 10 or 15 years ago. If you look in 2012, it's quite clear how the product mix, if you will, has actually changed for what dentists are choosing for their patients. And by contrast, if you also look forward into what projections are actually from, this information comes from dental laboratories, it's pretty clear that the trend is obviously there, that the use of metal in general is rapidly declining. And the all-ceramic full contour restoration or layered restoration of either one is rapidly becoming the new norm. Furthermore, some labs have actually now ceased productions of porcelain-fused to metal crowns because the demand is simply not there. And I think more to the point, the demand is simply not there for our patients either. And there's a number of reasons for this. This trend has begun some 7 years ago and will definitely continue into the future. So to make things simple, to help us understand really what ceramic materials are all about, I've decided to classify these materials as you might arrange them by process. The first class of materials that we actually had for ceramics that are still even currently used today are simply powder mixtures of water and the particular ceramic. This is rapidly falling out of favor, and what has now come into play have been the next two classes of materials, which are the machinable or pressable glass ceramics and the crystalline materials, which are now becoming even more widespread use, particularly since the early 2000s. And of course, their applications are many. We have them for full contour restorations as frameworks for a variety of bridges and for things like abutments for implants and a number of other things. Zirconia has piqued the interest of just about every clinician worldwide. You know, in truth, most dentists want things that look good, but they also want things that are perceived as being bulletproof. Now, bulletproof can mean a lot of different things, but the thing that you have to appreciate about zirconia is actually a metal. And it's actually a transitional metal at that. In dentistry, we use it as what's termed its dioxide forms, and it's been in early use since the 2000s. But what you may not know is that zirconia cannot exist in the way that we use it today without the benefit of digital technology. So technically, even dentists today who have no CAD/CAM technology in our offices whatsoever are currently using this technology to produce this type of restoration for their patients. It's a very exacting process to produce zirconia. But the first question that comes to mind is, why zirconia in the first place? Well, if you haven't noticed, and I think many of you have, there's been a lot of downward price pressure on materials or restorations that are currently coming out of laboratories today. In short, zirconia is widely available today. It's currently produced by a few manufacturers in a powder form that actually comes from a material or a mineral, I believe, called batolite. But we like zirconia for one simple reason, because doctors like white steel. White being cosmetic and the fact that they know it's strong. Now, strength means a lot of things or cannot mean a lot of things. More commonly, it comes down to appearance. Doctors like the idea that they can use something strong, which is comparative to, say, a metal that many of us are familiar with, which is gold. They like the idea that it can be actually made even in one piece, and it can be cosmetic. Cosmetic, of course, being a little bit different than what we term as aesthetic. But for molar regions, it's grown in popularity immensely. But another reason to think about zirconia is, in essence, it's relatively inert. It's been used in medicine for a long period of time. It's non-allergenic, and this is a critical factor for a lot of patients who typically have metal allergies, even to some things like gold. Furthermore, when it's smooth and polished, it's very kind to soft tissues. We don't have to worry about staining of soft tissues. And it's a low conductor for heat and cold, which is also an advantage to the patient. Another reason why doctors like to use it is it can be conventionally cemented, which in fact may be the preferable way to use this particular material. So in discussing white steel, we know it's strong, but in general, when you look at ceramics and porcelains and you put them in these two material classes, you'll notice that as the material gets stronger and it leans towards the crystalline side, which is what is zirconia, and as it gets weaker, which essentially goes back to the glass matrix type of materials, you'll get a higher level of aesthetics, the more glass, because you have a higher level of transparency. On the other hand, when you look now at the crystalline materials, they are much more dense. And you can tell by looking at the crystalline structure that you see in front of you that these materials have favorable attributes and ones not so much. But there's a lot of things that are changing in this regard. But first, let's understand just a little bit about what zirconia processing is all about. It's an exacting process. It goes through a number of steps as it starts out as a powder, and it has to be go through a number of careful steps to machine it properly such that it can be produced into what we call a blank. So starting out as a powder and going through these various stages, it's eventually going to reach this blank or puck, if you will, in a pre-sintered state. Zirconia can exist in three crystalline phases. At room temperature, the monoclitic form is what is associated with the stability at room temperature. Through a sintering process and through heating, it will reach what is called the tritagonal phase, or the intermediate phase. We call this metastable because it produces a unique property which imparts strength and crack resistance to this particular material. And in all cases, for dentistry, components are generally added to this material, more commonly yttria, which will actually enhance the properties of this material and contribute to its stability. And of course, a lot of doctors may not be familiar with this phase, which we will discuss at the end of this program, which is the cubic phase, is what we call the fully stable phase. But in all cases, for dentistry, zirconia is going to start the same way. But what we have to keep in mind, all zirconia is not created equal, because there's a lot of things that are associated with the production of this that affect its performance characteristics. As you see here, we see this prosthesis can be milled from this particular blank, but zirconia is typically milled. By milling, I mean it's not ground, which is typical associated with diamond instruments, but rather it's milled with carbide burrs. And it's actually overmilled to compensate for the shrinkage that will occur that is specific to each particular batch of zirconia. So simply stated, zirconia that's incorrectly processed with impurities and a number of other flaws in it can lead to poor performance. And unfortunately, a lot of doctors today are not familiar with where their zirconia is coming from or who is producing it. So I would suggest that you stick to the name brand manufacturers that are out there, or at least consult with your lab in this regard. Because properly milled zirconia will look dense and be relatively free of flaws. This is what you're looking for, because without this type of homogeneity in the material itself, it can eventually doom you, even though you think that zirconia is what you call white steel. Zirconia behaves rather uniquely because as the stabilized form is converted to the octagonal form, it will change under stress to what's called the monoclinic phase. But when this happens, what actually happens is you get a volumetric change, and it will increase such that when a crack is propagated, the crystal actually changes inside and squeezes down compressively, inhibiting the crack of the material from propagating through the material itself. This is what we call as transformation toughening. There's been a lot of evidence out there also to support the fact that zirconia works quite well. You know, I remember some 10, 11 years ago when zirconia first came out on the market, it piqued my interest because, like all of us, I wanted to eliminate as much metal as I possibly could for my patients, particularly along the aesthetic zone. And I remember I had a couple failures early on, and I was kind of a little bit discouraged. What changed my mind, though, is when I went back to a brand name Zirconia. And this is an example of the one that I've stayed with for pretty much most of my practice career using this particular material. There's an abundant amount of evidence that this particular material has worked well. And I think if you stick with a good lab, and I think if you also are conscious of the material that you're using and who's supplying it for you, you're going to see quite a bit of success. Now, when it comes specifically to zirconia, there are a number of studies that are out there that actually show us how zirconia actually behaves in the mouth. And, of course, in vitro testing is certainly not the same thing as in vivo evidence that we're all familiar with, but this is what evidence basis is really all about. And what we actually see is that particularly when it comes to lava zirconia, is that these particular specimens, when they're subjected to cyclic masticatory forces in a wet and dry environment, we see no significant decrease in strength for the lava frame zirconia. And in fact, this is what I've seen clinically in my own practice over the years. But at the same time, we also see that with the scattering, even with the data that we see here, that we can obviously see that the reliability factor for this particular material, particularly produced by this manufacturer, has not changed whatsoever, and we can be confident that we have reliability. Now, there are other studies also that have been around for quite some time, and this is an example of one where flexural strength is a function of artificial aging. As you can see or might expect, that the material will drop in terms of what its initial strength will to another lower level. But on the other hand, what we need to understand is that flexural strength is perhaps not the best clinical indicator in terms of how we would particularly choose a material, because we will discuss at a later point in time how to maybe rethink what we're actually contemplating when we're selecting material, particularly when strength is the critical factor. If you look carefully, and if you do a literature search, you'll be quite surprised to find that fracture is very rare in the literature. And I think based on this, we can have a high confidence level with regard to the material's usage and application itself. So let's talk a little bit here about what is becoming rapidly the new standard and perhaps why this may be so. One of the reasons monolithic has become popular, and this kind of really goes back to my own lineage and my heritage and my understanding of ceramics, having started with chairside CAD/CAM in the mid-90s. I knew quite honestly that the reason for the performance of what doctors perceived to be relatively weak materials, which were the glass ceramics, was a difficult thing for them to understand. And I think primarily it was because they'd had their own share of problems with them. However, most of the problems that we saw were actually materials that were constructed in a multi-layer type of principle. And what I would suggest to you is that there's a lot of evidence here that the monolithic trend is continuing and will continue to grow. And if we look at data that comes from various dental laboratories, in this particular case, we have Gladwell Labs actually here. You can quite honestly see that the PFM's day, the porcelain fused to metal crowns days or existence is rapidly declining, and it's rapidly being replaced by monolithic restoration. In this particular example, Bruxer, Emax CAD, and Obsidian are three of the forms that Gladwell currently offers. And in my discussions with laboratories all over the United States and Canada, I've pretty much heard the same thing from the leading laboratories, that they honestly feel that the monolithic trend is here and will continue to stay. The other thing I can tell you is what I hear from these particular people is that they tell me that dentists would be hard-pressed to tell the difference from a bicuspid all the way back to a molar made out of a monolithic block or milled out of a monolithic block as opposed to something that was hand layered. And there's a reason for thinking about this because of our understanding of really of how ceramics behave. You know, we typically veneer ceramics to provide aesthetics, primarily to cover either a metal coping or, in the case of zirconia, a relatively opaque core. And we also are well aware of the fact that chipping has widely been reported in the literature for this style of crown. But I would also submit to you that we've also seen the same things actually in our own clinical practice with porcelain fused to metal crowns. The question becomes, or maybe the question we should ask ourselves, is why not, therefore, if we can have a reasonably appearing restoration, why layer at all if it's not necessary? On the other hand, as I mentioned earlier, we've had very good experience with frameworks and coping, so it appears as though that the weak link or the weak element for this style of restoration is actually the veneering piece itself. Because as you can see here clearly, you'll see chipping either along the surface or, in the case of what can't be avoided many times, are simply porosities or inclusion bodies in the material itself contributing to the weakness of the veneering piece. Now, there are a lot of myths out there that are really associated with zirconia, but what we have learned and what we know currently is that zirconia does not behave like metal. Because in truth, the metal in a porcelain fused to metal crown can be poorly processed, and the fact of the matter is it will still work, but zirconia is not that way. There are a number of reasons why this happens. First of all, zirconia being an insulator, it's going to be very slow to heat and cool. And when the veneering piece is actually applied, and if those temperature changes are not accommodated for or put in sync, we're obviously going to have a problem or a mismatch. And there's other common laboratory errors that can absolutely be made. Many times it occurs on our part. For instance, when a doctor does a preparation, the preferential preparation would be that one of an anatomic form. Or if the laboratory gets one that is typically over-reduced, let's say, they should be producing a coping that has an anatomic form to create a nice, smooth overlay in known proper dimensions for the veneering piece that goes over it. We've all can relate to the fact that we have seen many porcelain fused to metal crowns chip. And if you look at them carefully, what you'll typically see is a very thin coping underneath them and an overabundance of ceramic, contributing to the weakness because the material itself was never designed to totally support the load of the masticatory system. The idea here is, and that what you should know, is that properly done, veneered zirconia, an example of one that I have used for a number of years is Lava Plus, has equal reliability to that of a PFM if it's done properly. My suggestion is if you do these style of restorations, your lab should be pressing the ceramic to the core itself. Now, doctors have also had questions about surface roughness, hardness, abrasivity, and a number of other things. Many doctors are fairly unfamiliar with the fact that hardness has really no relationship to wear. Rather, it's about smoothness. All right? So the smoother something is, the less wear you're going to get. The finer the structure and the detail, the less abrasive will be the material actually against the antagonist itself. If you look at these two clinical slides over here, scanning SEMs of one, a feldspathic porcelain, you'll notice it has a very rough and porous surface. And it's subject, actually, in the wear principle, to what's called brittle fracture. What you're actually seeing is brittle fracture at a microscopic level that's producing roughness in the material itself. Zirconia, on the other hand, when it's polished, is very, very smooth. And even during wear, it maintains its smoothness owing to the very small crystalline size of the material itself and not having a glassy matrix with essentially particles bound to it. You're going to get a very different wear principle as composed to the feldspathic porcelain. In short, being a transitional metal, if you will, the expectation, which is what we had from gold, it was a ductile, metal is a ductile type of material. Zirconia behaves in pretty much the same way. When it wears in a very, very smooth fashion, and removal of the surface itself, much like a metal, like gold would, involves ductile removal. So, in summary, what we know about antagonist wear of zirconia versus the feldspathics themselves is that the wear for veneered feldspathics are the highest. And going down the scale, rather, we can conclusively state that zirconia polished is definitely the lowest wearing material that you can put opposite any type of material that you currently use in dentistry. Monolithic zirconia has the lowest wear rates versus all other dental ceramics. And a number of studies out there have actually supported this fact. So if you're going to think about how you handle your materials at this chair, this may influence you with respect to how you want your laboratory technician to deliver this particular restoration to you. Now, we've covered the basic essentials of what zirconia is, where it came from, how it was developed, and a number of other things. And we also know that it's been now with us for 10 or more years. And we also know that there's an abundant amount of clinical evidence that this material is actually a performer in dentistry. To make any material perform, particularly when it comes to anything other than metal, it's important to understand the mechanisms or the behavior of the material itself and maybe how it's going to relate to how we actually finish these particular materials. Because the maintenance of the tetragonal phase in zirconia, which is what we're really trying to do here, is it's important to understand here is that all zirconias are not going to exhibit the same behavior in a uniform way. So if you ask me really what does this really mean to me, what I am saying is it goes back again to using a quality of zirconia. And we do know that the effects of aging in time can actually contribute, as we saw earlier, to a degradation in the flexural strength, at least in vitro, for the particular material. And this is, of course, associated with the conversion of the material back to the monoclinic phase, of which too much can produce actually a problem for the material itself and potentially contribute to early failure. So to understand this, surface refinement methods are a key component to this. Now, zirconia, if you have not used it or if you have more commonly used it and have had experience with it, you're going to notice that it's a very, very hard material. And it doesn't really lend itself well to a lot of adjustments. And particularly if you ever have to remove one of these things, you'll understand what I mean. It's not the easiest material to remove. But in order to understand really how to make this work better for us, we need to exhibit or demonstrate a fair level of care when it comes to protecting the restoration itself. One of the most common reasons zirconia can be influenced to failure is by simply not adjusting the restoration properly. So we want to avoid the buildup of a lot of heat. If you've not noticed, and I've done it once or twice actually with zirconia out of the mouth, if you lean too much on it, too much pressure, too much torque, too much speed, you're going to heat the zirconia up. And what you're essentially going to do is heat it up in a very small area. This will change the phase of zirconia irretrievably, and this is something that you want to avoid. Now, when adjusting zirconia, my recommendation is that we use diamond instruments, and I prefer actually clean diamond instruments. I use disposable instruments because the cost of a disposable instrument is $1 or just a little bit more, and it's not worth reusing these types of instruments on this particular material. I generally use a 20 or 40 micron diamond. So I'll trial seat my restoration, we'll mark, adjust it, and we'll do it with fine diamonds, of course. If you look in a laboratory, most of the laboratories will actually adjust this material with water, and if you do it in the mouth, that's actually possible for you. Then the next thing that you want to do is use a sequential sequence in terms of starting out by, first of all, eliminating deep scars, and that will naturally occur by not using a coarse diamond. Then, of course, we're going to go over, in generally what can be done a two-step fashion, to actually polish the restoration itself. My preference for zirconia is to have polished occlusal tables. And in this little particular sequence here, you'll actually see how this adjustment is done. So we trial seat the restoration, we get a diamond instrument, and then there are many systems out there, this is just one example of such, that can be used in a two-step sequence to polish the zirconia to a very smooth surface. A polished zirconia restoration will be so smooth, you'll be hard-pressed to hold it in your hand. So there's very low friction with a polished surface when it comes to zirconia, and it's my preference for use opposing any type of natural dentition. And you can see here, you want to bring the material itself up to a nice natural luster, and actually it'll have a very high shine to it. So let's talk a little bit about preparation and cementation, and I don't want to dismiss this in such a way as to diminish the importance of this, because many doctors don't understand that this is a function of the CAD/CAM process itself. And what you need to be aware of that these CAD/CAM systems have limitations, and lab technicians are actually limited in terms of what they can do. So in general, for a milled restoration, the idea is to have very smooth, rounded surfaces. Generally, you would want a mechanically retentive restorations, but you want to reduce or eliminate angles of any degree of sharpness whatsoever. There are minimal thickness requirements, of course, particularly if you're going to do a veneered restoration. But what we want to make sure is that we don't produce things that can't be handled by the CAD/CAM systems themselves. And these are things including J margins or gutter margins, peaked elements in the preparation itself, and undercuts, because these cannot be managed by the laboratory technician whatsoever. So pay attention to that. Now, when it comes to placement of the restoration itself, we have two choices. We can conventionally cement or adhesively cement. My bias on this is I'm going to conventionally cement where it's practical every time, and I generally design my preparations in such a way. On the other hand, you are going to need adhesive retentions, because many doctors do understand that past a certain level of taper, and generally we're going to get outside the range of between 15 and 20 degrees now, we're going to lose a fair amount of retention, particularly as we get past 20 degrees. So this is going to influence your cementation or placement method in terms of what you do. And also keep in mind that the smaller tooth itself has a shorter radius of rotation, so it's going to be more apt to be displaced as a patient chews or maybe gets something stuck to it. So this is going to influence you in terms of what you're going to do. But in general, properly done, most zirconia restorations should be designed in such a way that they can be conventionally cemented posteriorly. Now, when handling the material itself, we get a lot of questions, and I've gotten a lot of questions over the years on how to handle this. Your laboratory should be expected to sandblast this restoration with aluminum oxide. They should know how to do this at generally below 2 bar pressure or 30 psi. There's nothing fancy that has to be done to clean the surface of a zirconia restoration. The sandblasting roughens the surface, so it improves the ability of the cement to adhere to the material itself. What you simply want to do after you've done trying in the patient's restoration and after you've made your preliminary adjustments, all you need to do is rinse this with Clorox, sodium hypochlorite, and simply rinse it with water and dry. Then at this point in time, you can also make the choice alternatively of using a cleaning paste solution, which is made in this particular example by Ivoclar, which is a substitute for the method that I just described. In my case, we've got a lot of Clorox around our office, and knowing that it's effective, to me, it's perhaps the simpler way to do it, but in either case, you should do one of the two things. Now, when it comes to conventional cementation for the zirconia crowns and fixed partial dentures, the same concept applies. Assuming that the laboratory has air-abraded this, or perhaps you may have air-abraded it if the laboratory didn't, we're going to do it the same way. We're going to use sodium hypochlorite, water rinse, and/or our cleaning agent. At this point, you should also take care of the preparation itself. And I would suggest that you use something like Preppies or simply plain flour or pumice to simply remove the contaminants or the cements that you may have had attached to the tooth. And this will give you a sufficient surface, a good clean surface, to let the cement do its job properly. My choice for resin-modified glass ionomer cement, there are 2 or 3 of them out there. I've used the Reliax Luting Plus. for the simple reason, the high reliability factor, of course. But the other reason I do like it is because I can use my light to get a gel set and peel it away from the margins while I wait for the cement itself to eventually cure in its auto-cure mode. So I find it very convenient. Now, if you want to adhesively place zirconia, it doesn't have to be complex either. And the way I've tried to help doctors understand this is that you simply have to provide a clean surface for the zirconia. So the same concept applies here. You would try the restoration in the mouth, do your adjustments. But in a particular case here, what we want to do is use, same thing, we're going to use our sodium hypochlorite or our cleaning agent. We're going to clean the tooth, and we're going to use the self-adhesive resin cement. Now, Reliax Unicem 2 has been around for quite a long time. It's actually the first cement developed in this category. And in that sense, you are going to get a very strong bond to this material. And again, if you want to adhesively bond, this is my go-to for literally 90% of everything that I do, unless you run into the situation where you feel in a severely overly reduced or over-tapered restoration, not a lot of quality tooth structure to bond to, you may want to consider the highest level of adhesion you could get from a high-performance system. So our concept is going to be the same here. We're going to air abrade, sodium hypochlorite rinse, clean it with water or our cleaning agent, clean the tooth the same way. And now we're going to use Scotch-Bound Universal, which is a universal adhesive, but it's actually a universal primer. So it contains NDP. We apply it to the restoration surface, doctor applies it to the tooth, and now by using a compatible adhesive resin cement, we're going to get the highest bond values attainable with any type of adhesive systems that are available today. So, when we talk about zirconia, we talk about, of course, this YTZP zirconia, the tetragonal zirconia. That's a hard thing to say sometimes, get it all out in one time. But we know that the material actually works, and doctors like it. We have an understanding now why monolithic may be the way we want to go and what the reasons for that might be. The construction principle actually makes a lot of sense, but there are limitations. We know it's strong, and we know if it's handled properly, it'll perform, but it still seems to lack the vitality associated with restorations that we would like to do in the aesthetic zone, particularly as it applies to the idea that we would like to do potentially monolithic zirconia and eliminate the layering effect. So this is the exciting part that comes up now, because I think this is perhaps one of the most significant advances in the zirconia, what do they call them, chronicles, if you will, that really have piqued my interest. And I think you'll find this very interesting as well. What's come to be developed now by 3M is a unique product called Lava Aesthetic. So whereas Lava Plus could be done as a monolithic zirconia, or it could be done as a core zirconia and layered or as a frame, this material has been specifically developed to help doctors address issues in the anterior zone where the dead appearance of teeth commonly was the most common complaint with zirconia, and the lack of fluorescence. Vitality, as you know, is associated more with the fluorescence and to an equal amount with the transparency of the material itself. But what you need to keep in mind here, and we'll have a little discussion about this, this material was developed to meet that specific need. It is not developed, however, for the need for increased strength. Because the truth is, properly handled, whether you're using a glass ceramic or a crystalline ceramic like zirconia, with proper technique, we've had high survivability for all of these materials. We know this going back over the years and looking at CEREC restorations, which perhaps have the most abundance of clinical data out there that shows clinical trials of survivability of these restorations at 20-year marks exceeding or right at 90%. So what we don't have with this particular material, we don't, of course, have the clinicals that we would potentially like to have, but owing to the lineage of the material and going back to what we have seen actually with the material class itself, we have no reasons to expect that the material will not perform. But uniquely for this material, I think you're going to see a level of shading and fluorescence that is uncommon to any material that I've used to this point in time. If you look at Lava Plus, which is a tetragonal zirconia, you can actually see the crystals. And this is an example of a thermally etched sample of zirconia. The particle size for this material is right around the average of 0.5 microns. And this is how the material exists in its tetragonal phase. And if you think about light transmission and how this affects light and why zirconia may appear to be dead, what we have with tritagonal zirconia, the shape of the crystal itself redirects light in such a way that it creates a number of boundaries where each particular grain, as light passes through it, redirects the light in a different direction. This effect, known as refraction, or in the case of tritagonal zirconia, which is double refraction, scatters light. And it scatters light to the point where the restoration itself can look dead or relatively opaque. Cubic zirconia, on the other hand, in its pure form, in the cubic phase, in the case with lava aesthetic, the crystal size has actually been increased. And owing to the fact that a cube, or a square, if you will, has equal sides, you'll get a uniform light transmission, and there are less boundaries owing to the shape of the crystal. And by accommodating and mixing the correct proportion, perhaps, of the cubic phase with the tritagonal phase, the 3M engineers have actually been able to achieve a level of aesthetics which frankly rival anything that I have seen, particularly as it relates to what a lot of doctors like to use today, which is lithium disilicate. So we're going to get a lot more light transmission. And as you can see here, there's obvious differences because in this particular case, more light transmission actually comes through the material itself. So if you look at two slides here, the difference between lava aesthetic and lava plus, they've actually, I don't know how they do this, they've actually been able to optimize the crystal size itself. So there's a mix of cubic and there's a mix of tritagonal in the material. And because we have less light scattering, you get the more natural appearance that we've all been looking for. And in optimizing the aesthetics, and considering the fact now that this is intended primarily to be used in a monoclinical form, I think doctors are going to be very pleased with what they see, particularly as we move a little longer through the program. But on the other hand, the cubic phase itself, mixing it into the tritagonal phase, not mixing it, but allowing for both crystals to be there, does weaken the material itself. But I don't like to use that term because many doctors are confused about the strength issue. And here's my point. The first question a doctor wants to ask is, first of all, how strong is it? And I get that. I think we all get that because we want to look good and we don't want to have failures in our clinical practice. But the other question we have is how strong is strong enough? Well, we all know that as a patient loads their teeth, the loading factor is much higher in the posterior teeth than it is in the anterior parts of the mouth. The other question is, well, do we believe in vitro? I mean, the doctors will honestly say, you know, I see all these in vitro tests, but they don't mean a lot to me if things actually fail in my own clinical practice. So sometimes the relationship, many times the relationship, is not there between those two types of testing techniques. But what we do pretty much know is that a 500 Newton load, doing a literature search, is generally accepted as the one parameter that most restorations have to withstand to be able to perform reliably over time. But there's actually more involved in that because if dentists are given choices of materials, and I were to give them a bar chart, and I were to tell them that all the materials are to some degree cosmetic or aesthetic, they will behave in such a way that they will make the patient happy, the doctor's going to gravitate towards what? Well, generally they're going to go, okay, well, but I want the strongest, and if I can have, you know, my cake and eat it too, I'm going to go for the high bar. Well, what we should understand, and what I have understood over the years, and I've really learned, particularly since I've been doing glass ceramics since the early 90s, posteriorly in the mouth, is that the flexural strength value, while important, generally doesn't really correlate well with clinical performance. And most of the data in the literature actually supports that. Yet this is the one mechanical principle or one mechanical property that we tend to gravitate towards. I'm actually, in my discussions with doctors and presentations that I've given over the years, I've always been confused by this because early in my career, having started with the glass ceramics and applying them properly, even though that flexurally they were relatively weak compared to other materials, they've always been able to perform. The chief reason being is that we're finally getting smart to the point to where we can make sense of all this because a better indicator of clinical performance is actually fracture toughness. Fracture toughness is related to the ability of a material to withstand the propagation of a fracture through it before failing. And in understanding what this relates to, it relates actually to the way the material behaves in the mouth. So flexural strength is actually a test that's done outside the mouth. Fracture toughness is actually testing that can be done in vitro, which actually simulates oral function. And now we have finally come to our senses in understanding that we can actually categorize the materials using scientific principle known as ISO standards, which has been common to just about every other industry, any level of engineering to it, to create a standard for dentists to understand how these materials can be classified. And in me starting out here with the glass ceramics actually early on in my career, these materials, if you look at them, they're relatively low flexural strength. They appear to be relatively low in fracture toughness, yet they still work, primarily because the fact that they were done properly with good adhesive techniques and understanding that ceramics are in fact brittle materials, but they respond very well to compressive loading. And by using proper adhesive technique, as evidenced by CEREC over the years, and to the first company or the first principal that actually brought this to the forefront, it's no wonder these materials have worked, because we understand now that flexural strength isn't the sole criteria for the performance of the material itself. And in understanding how the classification can work as we move up the scale, we can actually see here that fracture toughness more aptly correlates to how we can expect the materials to perform. And dentists, as they begin to look now to the zirconia style of materials, and it's quite clear here that you go, wow, this is really what I want. I mean, look at this. I've got 1,000 megapascals of strength. I got a high fracture toughness. It exceeds everything that's out there. Well, the point being is this. If the one at the bottom worked, we can certainly expect the one at the top to work. So how strong does something really have to be? The answer is it depends on technique and it depends on application. When we look at lava aesthetic, this material fills a very unique niche. And I think what I am seeing here is it gives me a broad range of application to apply it in virtually any area of the mouth. If I need a single monolithic unit in the anterior regions of the mouth, or even in situations where I might like to have a 3-unit bridge without a coping, or without a framework, rather. So I think now, in conjunction with what I have said, we actually have material scientists. Here is Dr. Bob Kelly, who actually states the obvious, and that I'm sure he has known over the years, is that we finally have a way to help dentists understand how we can classify materials in such a way that we can give them an application range for their use in clinical practice. The other factor about this particular material, which I find really unique, over the years I've used polychromatic blocks, which were a function of the chairside milling system. In other words, the shading for the restoration was actually built into the material without the application of external glazes or tints, for which we know will eventually wear off. So something that's obviously built in is obviously an advantage to all of us. This material has intrinsic shading actually built into it, and you can see an indication here by looking at the shade tabs. Very closely it approximates what we typically associate with the standard for shading. The way the material is actually built, it's built in such a way that the puck is actually turned sideways here. It actually is built into a number of incisal zones, so the thickness of the puck actually varies. In this particular case, it could be an 8 or 12 or 16 millimeter body zone. And if you'll notice, the way the shading is intrinsic to it, it's actually built in such that the restoration, the technician can actually take this particular to-be milled restoration and actually position it within the gradients to get the maximum effect of the gradients, giving it that more vital appearance and potentially eliminating the need for tints, which eventually wear off. More interestingly is the level of fluorescence. And fluorescence is a very, very difficult thing for a patient to understand, but it's easy for a dentist to understand it because ultraviolet light exists in the presence of all light. It can be in room light, outdoor light. And UV light, a natural teeth fluoresce. And a material that approximates a tooth, particularly dentin, should fluoresce in the same way to avoid the appearance of a core, beneath the material or the opacity of the core itself with relationship to the tooth underneath it. So in trying to attain this, I think they've done a really good job here in taking this particular material and giving it a nice level of fluorescence that compares very favorably without the use of fluorescent glazes. Additionally, what I appreciate is the fact that this material can be used confidently at what I would suggest would be a 1 millimeter reduction and taken to a minimum of 0.8 millimeters. I like to use 1 millimeter as the reference simply because it's very difficult for me to see 8/10, but I can associate myself with 1 millimeter. But we do know that with a high level of confidence that this material can be used in minimal reduction situations, and this is the mantra of dentistry today now, is minimally invasive concepts. I have a high level of confidence given the fact that it's zirconia. It has the mechanical properties that I'm looking for, and now it has the level of translucence and fluorescence that I'm looking at, to think that this material can actually be perhaps where we've always wanted this material to be in the first place. I like the idea of more conservative preparations with lifelike aesthetics. And you can see here diagrammatically, and by the way, I'm not sure I trust any glass ceramic at a 1 millimeter thickness, particularly given the differences between the two materials. Structurally, they're different materials. In my experience over the years using glass ceramics, I am more confident in a minimal reduction situation with 1 millimeter than I would be for any of the materials that are currently on the market today. When it comes to bridges, the connector sizes have to be specifically designed by the clinician, and the clinician can influence the dentist or can contact the dentist with respect to potential problems when it comes to this. So the technician and the dentist can work together as a team. One thing I would like to point out, zirconia, unlike glass ceramics, can be adjusted in the embrasure areas with instruments. Lithium disilicate cannot be adjusted. Typically, with any type of cutting instruments, once the material is machined, or at least to my knowledge, it's been contraindicated to do so, the technician does have a little bit more latitude in this regard. So adhesively, when you want a cement lava aesthetic, and the tooth preparation concept is simply going to come into play. Make sure your dentin is moist. That's a requirement for whether you're conventionally cementing or whether you're bonding your restoration in. Clean the restoration, the tooth preparation properly. Do not use any type of acid on the integral surface of the material, because hydrofluoric acid has absolutely no effect, and orthophosphoric acid, 35%, 38%, has a negative impact because it contaminates the restoration with phosphates that are also present in saliva. It's very simple. This material, lava aesthetic, you should use a self-adhesive resin cement in nearly all cases. Clean your preparation. Hopefully it's pre-sandblasted. If not, 2-bar pressure. Take your restoration. If you need to rinse it and try it in, rinse it off with sodium hypochlorite, water rinse, dry it. Put your cement in, 1 second, light cure. I use a light curing instrument that has a 1-second timer on it. And when I use it with Unisem 2, 1 second's perfect. I can peel the cement off nice and cleanly, let it set in the auto cure mode, and you're done. There's a lot of evidence out there that tells us that self-adhesive resin cement are more likely than not to be the preferred way to adhesively cement zirconia restorations in place, because the incidence of failure with these is actually quite low. There's a number of other examples that have been done and shown to prove that the bond strength with Unisem 2 is actually quite good with the Lava Plus, and we have no expectation that this is going to change, as you can see here with the Lava aesthetic as well. Very high flexural strength and very high compressive loading. The one thing I would tell you is that saliva contamination is a factor, so please make sure that the saliva is removed and dissolved by using sodium hypochlorite, or, as I mentioned earlier, you could use a cleaning agent to decontaminate the restoration, rinse and dry it, and you're ready to go. If you need a higher level of bond, you're going to use a high-performance system, and of course this would involve a separate adhesive primer. MD Scotch Bond Universal, which I call a universal primer, can be used in conjunction with the Reliax Ultimate Cement to get a very efficient and stable bond to the material. And again, at quite a bit higher level, rather, from the Unisem 2. And what we know about antagonist wear is no different than what we know about zirconia in general. It's very favorable. The polished surface seems to be the way to go. So if you're going to work with your lab on this, surfaces that come in contact with teeth or antagonists, if you will, of any type of material, I would prefer them polished. And in general, unless staining needs to be done for a particular reason, because you just can't get the right things, like, for instance, some fluorosis or some decalcifications, those can be externally applied, but generally only for a cosmetic improvement. And John Burgess at the University of Alabama concludes that this material in the polished state agrees with the studies that we have seen earlier in this presentation. So I'm going to just show you a case here, and this case particularly applies to a case that I started with. And what you're actually looking at is a case that was done in all glass ceramic restorations a number of years ago. And this wasn't an ideal case, and this is the first case I actually did with lava aesthetic. And you'll notice here that we have a non-vital tooth on tooth number 9 over there. And the rest of the restorations are done. We have 4 restorations, and the treatment plan for this particular patient is to do crowns on teeth numbers 6 through 11. So we did the usual types of things. We took our chromoscope shade guide. I was actually concerned about the dark stump that you see on the central incisor as referenced by the yellow arrow, because I wasn't exactly sure how this material was going to behave with respect to hiding the stump itself. Furthermore, I was at the mercy of the clinician who did the preparations before me in terms of what level of reduction. Ideally, I would have probably preferred about 1 millimeter or so reduction, nice, smooth, rounded prep forms, but I was able to actually get these things prepped out quite well. And what I did here was when we took the shade for the restorations, the patient wanted to match to her lower teeth, even though she has a deep bite, you really can't see her lower teeth. And in my experience, 4M1 shades can be difficult to produce in laboratory settings because many patients typically want the more lighter restorations, but this wasn't indicated for this patient. So the particular laboratory I used was Thayer Dental Laboratory in Mechanicsburg, Pennsylvania, and they were one of the first labs in the United States to gain access to this material. I would hardly encourage you to seriously think about a digital lab workflow for everything we do. We do not take impressions in our office and haven't for quite some time. If you have access to any level of a digital impressioning system, or if you're currently thinking or been on the fence about it, you need to complete this part of the workflow. It'll save you time, it will save you money, and it will greatly enhance the effect or the result that you'll get actually from your dental laboratory. Many laboratories are often actually less today because many of these single restorations can be done simply without even a model. In this particular example, we've taken the case, and here you would want a full model so the laboratory can actually see the emergence profiles and the things associated with the anterior teeth. And you'll see the digital model that's actually been printed or produced, and you'll see the material actually here. Now, you never know what they're going to look like when you get them in the mouth, but what I can tell you, you can expect these restorations to fit when they're done through our digital workflow. In the many years of doing restorations lab side, I can attest to the fact, and we have studies actually to this effect, that they fit better and they take less time to place in the mouth. Other advantages of digital workflow: that technician can actually, in our case, we actually pre-scan the patient, and then from the pre-scan, the technician can actually lay over and produce restorations that align precisely with the midline. I requested incisal lengthening of about 1 millimeter, 1.5 millimeters, and the technician can actually control even where the occlusion goes. I wanted a strong material for this particular patient, and I did not want a layered material because I wanted the advantage of strength with a fair amount of, without over-reducing, particularly in these cingulum areas where occlusion actually comes into play. In a deep bite, as you well know, you have to have, with glass ceramics, a much thicker glass ceramic substrate to support that level of occlusion. In this particular case, as you look here, you can see on the one slide where the technician was able to actually design the occlusion where it was supposed to be. So in putting this all together, we had the restorations milled out, we brought them back to the patient, and we actually put them in the mouth. And in my opinion, for the first case I did, we had some external tint applied to compensate for the discoloration on the lower arch around the canine region, as you can see here. But overall, I was just overwhelmed. The patient was just actually overwhelmed by the overall aesthetic result and the level of enhancement that we actually gave this patient. And with me walking away the idea that I got a high level of confidence in terms of performance, I think it's a win-win for everybody. If you look at the before and after here, it's quite clear to me that this particular patient received maximal level of care. And the ease with which we were able to place these restorations, and I know you hear dentists oftentimes say, well, I did nothing to it. These restorations, the contacts were exact. There was no occlusal adjustments that were done with it. We cemented them, the restorations in using a self-adhesive resin cement, in this case Unisem 2. You can see the fit here clinically. I'm also currently now gravitating the fact that I'm moving to the molars. If you look at the light transmission, this is the one thing I want to point out. You'll notice that you can see the stump underneath the particular restoration itself when light shines through it. But what I like and what I appreciate about this particular material is the warm glow that it actually has without the appearance of any coping that's underneath scattering the light. And they look just like natural teeth. I can't say enough about this, and we're using it a lot more. We've actually moved to the posterior regions of the mouth with it. And this is actually the first molar that I did with it. You'll also notice that this fellow has some tori. So the patient this is a high loading situation. Remember this, is that strength is overrated. Properly used, virtually any glass ceramic in the mouth you can have a high level of confidence with. Doctors want the insurance. I believe that if doctors pay more attention to the techniques and the preparation principles and placement principles associated with them, and now we have the fact that we have aesthetic fluorescent materials that could be used in any areas of the mouth, I have a high confidence level that for single unit crowns, bridges, multiple units, that this can potentially be the new go-to material for dentists. So finally, in summary, where is this going? What's happening? Well, as a final comment, I would say, is zirconia going to be the new mantra for the next 10, 20, 30 years in dentistry? I don't know. But what I do know is that the advancements that I'm seeing now with zirconia, particularly with this latest advancement, which is unique, I have a high level of confidence that for crowns, and crowns being the way they can be produced, I'm seeing better restorations at a lower cost with a higher level of patient's acceptance. And I think it's quite clear that zirconia is going to have a place. It won't be the all to end all, because I also believe that we also need other materials that can be manipulated in the mouth, which zirconia cannot be easily. I think we need to accommodate patients that have structural issues. They have periodontal issues, because I don't always believe a stiff material is going to be the right material for a given particular patient. But what I can say is that you need to be on the digital front end of this, because everything you're doing future forward today, and even more so into the future, will be done digitally. And if you want to use these materials, you're missing the boat if you don't put that digital piece on the front end. I'd like to thank you very much. It was a pleasure to be with you today.
Thank you, Dr. Patikny, for your excellent presentation. My name is Jeffrey Morris, and I'm a Scientific Affairs Manager with 3M Oral Care Solutions. So we have a few questions from the audience, Dr. Patikny. When cementing with Reliax Unisem cement, do you need to use a dedicated primer on the zirconia surface? Dr. Patikny?
The answer is no, and oftentimes it's confusing. It's one of the things that I truly appreciate about Unisem 2, because it's incorporated into the cement. So you do not need an additional primer, such as MDP, to get the kind of results you expect for adhesive cementation.
So a second question. Can you remind us as to what amount of occlusal reduction is needed for lava aesthetic zirconia? Dr. Patikny?
Well, the material itself has been tested at 0.8 millimeters, but being a clinical dentist and being someone that practices day in and day out, I can't tell you really what 0.8 is all about. I can tell you what 1 millimeter is. And my suggestion to you is, if you stay consistently at 1 millimeter or above, you're going to have excellent results with no worries at all. I begin to get a little concerned when doctors try to say, well, I've got 0.8, it was close to this, that, and the other. I say if you stay at 1, you're going to have absolutely no problems. You'll be very satisfied with the performance long term.
All right. What type of margin design is preferred when using lava aesthetic zirconia? Dr. Patikny?
I could answer this two ways. I guess the way I am going to answer this is what lab technicians tell me, and I believe it's correct. I would recommend a slight chamfer. Yes, it's true technically that you can do what doctors refer to as a knife edge, but they can be difficult to read, either through an impression, even sometimes in digital impressions. So my suggestion is, being that there's very little difference between a light or a slight chamfer and a knife edge, my suggestion is a slight chamfer.
Okay. And finally, one last question. What height of the tooth crown is minimal to produce a restoration from zirconia in the posterior area? Dr. Patikny?
Well, you can produce a restoration on any type of preparation, following the proper preparation principles. If you're referring to how much height do I need to retain the restoration, you would think about zirconia much like you would think about a metal or a full contour all-metal restoration. And the standard generally is 4 millimeters for doing conventional cementation. Now, as you begin to lose clinical height and maybe taper comes into play, you're going to have to think about adhesive cementation. Keep in mind that the restoration is a milled restoration. It's not waxed to a die, for instance. So being digitally designed, I would say, if you're going to talk specifically about a crown, you definitely want, I would say, no less than 2 millimeters of clinical crown height. But again, at that point, you're going to be thinking about adhesive placement for the restoration. On the other hand, if you have 4 millimeters height, in that range right there with a relatively low degree of taper, you're going to be able to conventionally cement that. I hope that helps.
Well, that was very good. That was our last question. So I want to thank you, Dr. Patikny, again for an outstanding presentation, and I want to thank the audience.